Hi, this is Dr. Sherry Shabowski from Medical Education in Minutes. If you like this topic or this kind of information, please like and subscribe to my YouTube channel. Today we're going to be discussing hemostasis and anticoagulation. So let's go. Hemostasis is divided into two steps. The steps are not entirely distinct, but primary hemostasis describes the development of the platelet plug, and secondary hemostasis describes the reinforcement of the platelet plug, creating a stable clot. Clotting is balanced by fibrinolysis because what is built up must come down. This describes the continuum of hemostasis. Now let's talk specifically primary hemostasis. The illustration shows the endothelium in red, the underlying connective tissue in blue, and the smooth muscle in brown. We are going to discuss what happens when you have a vascular injury. Let's start with inactive platelets, which are continuously circulating, prepared to take action if action is necessary. Endothelin is released from damaged endothelial cells, which causes the smooth muscle to contract, closing the gap so the bleeding is minimized. I mean, some injuries are more extensive than others, so smooth muscle contraction and vasospasm are critical parts of hemostasis. When the vessel is injured, von Willebrand's factor is exposed. Tissue factor 3 is also activated by damage to the vessel. Platelets are activated and attached to the von Willebrand's factor by way of glycoprotein 1b. These platelets call in more platelets. The activated platelets secrete glycoproteins that attract more activated platelets. These platelets stick together with glycoprotein 2b3a. In the background, while the clot is being made, there is clot retraction and vessel repair going on. Actin and myosin, contractile proteins within the platelet, pull endothelial cells together, closing the hole. Platelets, endothelial cells, and fibroblasts secrete platelet-derived growth factor. Platelet-derived growth factor, or PDGF, causes mitosis of smooth muscle cells and patches connective tissue. Platelets and endothelial cells secrete vascular endothelial growth factor, or VEGF, which regenerates the new endothelial lining. So now we have a platelet plug. Let's move on to secondary hemostasis. It's time to reinforce the platelet plug. Most clotting factors are made in the liver, and they circulate inactive in the blood. The exceptions include factor 8, which is made by endothelial cells, and factor 3, or tissue factor, which is made by fibroblasts. Let's start with the intrinsic pathway. The sticky plug is negatively charged, and it attracts factor 12 Hogmann factor and activates it. This is the initiation of the intrinsic coagulation cascade. Activated factor 12 activates factor 11, then activated factor 11 activates factor 9. Factor 8 interacts with factor 9 plus calcium, and this activates factor 10 in the common pathway. So here is an illustration of the intrinsic and extrinsic arms of the coagulation pathway that lead into the common pathway. On the last slide, we were following the intrinsic arm of the coagulation pathway, which ultimately ends at the activation of factor 10, which is common to both pathways. The activated factor 10 combines with activated factor 5 and calcium, creating the prothrombin activator complex, which converts prothrombin into thrombin. Thrombin in the common pathway is really important and has many functions. First, it activates circulating fibrinogen, which is soluble, and creates insoluble fibrin that reinforces the platelet plug. Thrombin also activates factor 13 that is responsible for cross-linking the fibrin into a mesh that reinforces the platelet plug, creating a stable clot. This clot maintains a cap over the injured vessel, giving it time to heal. Now let's consider the extrinsic arm, which we saw activated in the previous slide. The extrinsic pathway is triggered by tissue injury, inflammation, and infection. Factor 3 is made by fibroblasts. In our case, tissue injury exposed factor 3 and activated it, which combines with factor 7 and activates that. Factor 7 activates factor 10, and now we're on the common pathway again. Anticoagulation on the intrinsic side is represented by the prothrombin time, or PT. Anticoagulation on the extrinsic side is represented by the APTT, or activated partial thromboplastin time. Both may be affected when the common pathway is directly affected. Some clever person made this memory tool. You play table tennis, get it? PTT, inside. So that's the intrinsic side. You play tennis, PT, outside. And that's extrinsic. Here is an overview. Injury to a vessel triggers both arms of the the coagulation pathway. Exposure of tissue factor triggers the extrinsic arm. Von Willebrand's factor in the subendothelium is exposed by vessel injury, calling in platelets to form the fragile platelet plug or sticky clot. The platelet plug is negatively charged, and this negative charge attracts and activates circulating factor 12, or Hogman's factor, which initiates the intrinsic arm of the coagulation cascade, ultimately resulting in a fibrin mesh that stabilizes the clot. Build it up and knock it down. Hemostasis needs to balance clotting and bleeding. Unless you want every clot that is ever made in your body to remain there and cause vascular obstruction, we're going to need a mechanism to break them down. And this is called fibrinolysis. The same fibrin that creates the stable clot by turning fibrinogen into fibrin and also acts on the endothelial cells and causes them to release tissue plasminogen activator. TPA converts plasminogen into plasmin. Plasmin is a fibrin chewing machine that stabilizes and breaks down the clot. When clots are broken down, they release fibrin degradation products and D-dimer into the blood. The fibrin is broken down, thereby breaking up the clot and releasing D-dimer and fibrin degradation products into the blood. Sorry about the repeat. We have now reviewed the action and reaction to vessel injury. But with all these clotting factors and platelets constantly circulating, what prevents clot formation on a daily basis? Well, endothelial cells secrete nitrous oxide and prostaglandin I2, also known as prostacyclin. These keep the blood flowing. Nitrous oxide causes vasodilation, protects endothelial cells, and inhibits aggregation of platelets. Prostaglandin causes vasodilation and inhibits activation of platelets and their adhesion. Heparin sulfate, a glycoaminoglycan on endothelial cells, binds and activates antithrombin 3 that degrades and inactivates clotting factors 2, 9, and 10. Thrombomodulin on the endothelial cells binds thrombin, or factor 2, taking away its thrombotic properties and triggering its fibrinolytic action. It also activates protein C, which actively degrades factors 5 and 8. Should we test my teaching skills and see if you can make the jump to how medications work? Let's give it a try. All right, let's start with the logic. If you want to prevent clot formation to a small degree with minimal effect on the clotting process in an emergency, you're going to want to keep those platelets moving along. If you have a clotting disorder and or need to inhibit clot formation, you're going to want to block the common pathway of the coagulation cascade. Aspirin blocks COX-2. It is a COX-2 inhibitor. What COX-2 does is it triggers thromboxane A2, which increases platelet aggregation and decreases blood flow. When aspirin blocks this COX-2, it will decrease platelet aggregation and increase blood flow. This effect lasts for the life of the platelet. All right, let's go bigger now. Let's start with things that block the common pathway. And let's start with warfarin. It is the oldest anticoagulant, and it is a quirky little bugger. It is a vitamin K antagonist. Warfarin works by inhibiting an enzyme responsible for recycling and making vitamin K active. Without active vitamin K, the liver cannot properly activate specific coagulation factors like 2, 7, 9, and 10, leading to anticoagulation effects by essentially blocking the common coagulation pathway plus more. Vitamin K is an essential cofactor in the production of protein C and S. Without protein C and S, you will get a transient hypercoagulable effect. And this effect precedes the effects of the effect on the factors by a few days. So first, warfarin makes the person hypercoagulable, and then it anticoagulates them. This has the potential for disaster if the person needs anticoagulation. To remove this potential for disaster, heparin, and typically low molecular weight heparin injections, are given at the beginning of warfarin therapy to provide anticoagulation through this transient hypercoagulable phase. This is a warfarin-induced skin necrosis, which is a potential complication from the initial hypercoagulable state. Hopefully, this helps you to remember that you need bridging heparin when you start warfarin, if you actually do that. So, what if someone on warfarin starts bleeding? Well, then you're going to have to reverse the effects. The drug activity will be indicated by the prothrombin time, or PT. This is an oral medication, so no shots are necessary. But it's inconvenient because it requires blood draws for PT and INR regularly. Something as simple as food intake can alter the efficacy of the drug, such as leafy vegetables. In situations where the PT is elevated past its target, but there are no symptoms, holding warfarin therapy would be the answer. Warfarin works by inhibiting an enzyme responsible for recycling and making vitamin K active, as we said. Without active vitamin K, the liver cannot properly activate specific coagulation factors, including 2, 7, 9, and 10. Replacing active vitamin K allows activation of those factors and reverses anticoagulation. This is a slow process. It may take days to work, although at the end of it, you will have complete reversal of the effects of warfarin. The IV administration is faster than PO, but both are reasonably slow. What if the bleeding is more severe and you need something done fast? Well, fresh frozen plasma, or FFP, provides immediate replenishment of all plasma proteins and coagulation factors, including 2, 7, 9, and 10. Now it is frozen, So you're going to have to wait a little time for it to thaw before you can administer it. And you often need quite a bit of FFP to reverse the bleeding immediately. Therefore, this may be a large volume, and not every patient can tolerate large volumes of proteinaceous fluid. Next is prothrombin complex concentrate, or PCC, which provides a concentrated intravenous source of the vitamin K dependent clotting factors 2, 7, 9, and 10 that warfarin inhibits. It's readily available. Most hospitals have it. It's faster and less volume than FFP, although you can use the two in combination to decrease the volume of FFP you need. It does have a higher risk of clotting complications than FFP, but it should resolve the anticoagulation rather quickly. Recombinant factor 7A can only be used in the most dire of circumstances that outweigh the very real risk of venous and arterial thrombosis associated with the administration of this drug. It pushes the extrinsic pathway to increase clotting, and that it does. Using it in this case would be an off-label use. Therefore, the patient, you would have to know that they were going to die from their bleeding if you couldn't reverse it completely. All right, let's talk heparin now. Heparin blocks the transition of prothrombin to thrombin and fibrinogen to fibrin. So basically, it blocks the final common pathway. But heparin does not act directly on the coagulation system. In fact, what it does is it activates antithrombin 3, which blocks the conversion of prothrombin to thrombin and fibrinogen to fibrin. Here I'm showing you some indirect factor 10A inhibitors. These are the low molecular weight heparins. They act on 10A, much the same way as heparin did. It's indirect. It activates antithrombin that blocks prothrombin from becoming thrombin, and to a lesser extent, fibrinogen becoming fibrin. Now, what if you have someone hemorrhaging who's on one of these medications? Well, then you're going to have to reverse the heparin. Protamine sulfate neutralizes heparin and low molecular weight heparin through an electrostatic interaction. Heparin and low molecular weight heparin are strong negatively charged anticoagulants. Protamine is a strong positively charged protein that combines with the heparin and neutralizes it. Dosing depends on how much heparin or low molecular weight heparin was given and how long ago it was given. Now let's talk DOACs. Direct oral anticoagulants are DOACs. They directly block the activation of factor 10. DOACs are very popular. They are convenient oral medications and do not require any blood tests. They do not require blood tests because the PT-PTT do not reflect whether the medications are therapeutic or excessive for that matter. Since it is not reflected on blood tests, this makes a review of the medications extremely important in your patients that are bleeding. In case of an emergency, you can reverse the DOACs. First, you have to know they're taking them with a drug called andexanet alpha. This is an antidote. It binds to and sequesters factor 10A inhibitor molecules. It may cause clots or infusion-related reactions. Alternative to this medication, if you don't have it, is the PCC or APCC that contains one more factor. Dabigatran is a DOAC, and it's a moneymaker. It's slightly different because it's a direct thrombin inhibitor. And where it makes its money is it requires its own very specific antidote. I'm not even going to try to say this name. This antidote is a monoclonal antibody that binds and inactivates the drug. Potential thromboembolic events may be serious, and you may have an allergic reaction to the medication. And here's a crazy one. You may have fatal reactions in patients with hereditary fructose intolerance. So I guess that means if you're ever considering using dabigatran, you better find out if your patient has hereditary fructose intolerance. Alternative to this drug include PCC and APCC if it is not available. Remember this one? The clot busters that can be used for heart attacks and strokes are IV tissue plasminogen activators that cause the creation of a large amount of plasmin. And you know, plasmin is a crazy fibrin eater, so this medication is going to break up clots. It works very quickly, but it can cause unwanted bleeding because it pushes the hemostatic balance toward bleeding. Yeah, that was a lot. Perhaps you'll need to listen to this one a couple times before you get all the information into your noggin. All right, thank you for learning with me. More basic course content is available at www.medicaleducationinminutes.com. If you like this content, please like and subscribe to my YouTube channel. And remember that the more you know, the better you are. So keep studying, and I'll see you next time.